Today, we shall learn about guided tissue regeneration. The aim of periodontal therapy is to prevent further attachment loss and to predictably restore the periodontal supporting structures which are lost due to the disease trauma. And the role of conventional non-surgical therapy and periodontal flap surgery has been established, and this help in halting the disease progression. However, it results in poor aesthetics in anterior dentition and also residual periodontal pocket which are inaccessible to effective cleaning. This leaves a negative effect on the long-term prognosis. However, to minimize these complications, periodontal regenerative procedures were introduced to restore the lost periodontal tissues. So, periodontal regeneration involves the reformation of epithelial cells, the deposition of new acellular extrinsic fiber cementum, insertion of functionally oriented connective tissue fibers into the root surface, and to restore the alveolar bone. And in 1976, in a review paper, Melcher suggested that the type of cells which repopulates a root surface after a periodontal surgery determines the nature of attachment that will form. And this is called as Melcher's concept or tissue compartment hypothesis. That is, after a periodontal surgery, the type of cells which repopulate or arrive at the wound site will determine the nature of attachment. And there are 4 types of cells that can repopulate in the wound site. They are either epithelial cells, gingival connective tissue cells, bone cells, or periodontal ligament cells. And the long junctional epithelium is formed if the root surface is first repopulated by the epithelial cells. If it is repopulated by connective tissue cells, then it results in connective tissue adhesion and root resorption. If the area is repopulated first by the bone cells, then it results in ankylosis without any periodontal ligament cells. But if the area is repopulated by periodontal ligament cells, then it results in new attachment and bone regeneration. So the type of cells which repopulate in the area or at the wound site after a periodontal surgery determines the type of attachment. So guided tissue regeneration prevents the apical migration of gingival epithelial cells and connective tissue cells, and it maintains an wound space into which a selective population of cells can arrive. So that is the goal of regenerative procedures. So to define it, these are procedures attempting to regenerate the lost periodontal structures through differential tissue response. So in this image, you can see a guided tissue membrane is placed between the epithelial cells and the bone defect. And this guided tissue membrane or GTR membrane will prevent the epithelial cells and the connective tissue cells from migrating into this area, while it allows only the periodontal ligament cells and the bone cells to repopulate in this area. So as a result, since the periodontal ligament cells arise at this area, this results in new attachment. So this acts as a membrane. It not only acts as a barrier membrane, but also it creates a wound space, or it maintains an wound space for a new type of cells to repopulate in the area. So according to the research by Nyman and his colleagues, the periodontal ligament and perivascular cells have the capacity to regenerate the attachment apparatus on the tooth. And this is the concept of GTR. That is, by utilizing a barrier membrane to facilitate the migration of bone cells and periodontal ligament cells to the defect by preventing the epithelial cells and connective tissue cells from penetrating it. That is, in this image, you can see a barrier membrane will prevent the bone cells and it prevents the epithelial cells and the connective tissue cells reaching the site while allowing the migration of bone cells and periodontal ligament cells. And the periodontal ligament cells have the capacity to regenerate the attachment apparatus of the tooth. So now we'll see what are the indications of GTR or guided tissue regeneration. It can be used successfully in class 2 furcation to treat recession defect, to restore the periodontal ligament attachment in narrow 2 or 3 walled infrabony defect or vertical bone defect, to augment the alveolar ridge, to repair of an apicectomy defect, osseous fill around immediate implant sites, and to repair the osseous defects associated with a failing implant. So these are some of the indications of GTR. While it is contraindicated in a one-walled vertical defect or in a one-walled intrabony defect, when there is an multiple adjacent defects, if the width of attached gingiva is not adequate, in grade 3 furcation, in horizontal defect, and also in the cases where there is a flap perforation, because the GTR membrane should not be exposed. So these are the indications and contraindications of guided tissue regeneration. Next, we'll see some of the ideal properties which are required for the GTR membrane. The membrane should be biocompatible or it should allow tissue regeneration. It should not be toxic and cariogenic. It should be chemically inert. It should be able of being sterilized. It should be easy to handle during surgery. It should be sufficiently rigid so as to maintain a space between it and the root surface. It should be supplied in different designs to suit the specific clinical situation. It should be easily stored and should have a long shelf life. It should be easily retrievable in case of any complication, and it should be cost effective. These are the ideal properties that a GTR membrane should possess. So now we'll see the materials used for GTR. It can be natural or synthetic, and it can be either a resorbable one or a non-resorbable one. The resorbable one usually used are collagen, calcium sulfate, and synthetic polymers like polylactic acid, polyglycolic acid, and polylactate. While the non-resorbable one commonly used are millipore or methyl cellulose acetate and expanded polytetrafluoroethylene. So these are the membranes, either natural or synthetic membranes can be used, which are either resorbable or non-resorbable. There are some limitations for both resorbable and non-resorbable. So one of the limitation of a non-resorbable membrane is that there will be a chance for early spontaneous exposure to the oral environment, and a second surgical approach is required to remove the non-resorbable membrane. That is, after 6 to 8 weeks after our initial or first surgery, we need to perform a second surgery to remove the membrane. While in the case of a resorbable one, there is no need for such second approach, but there are chances for early membrane degradation and epithelial downgrowth. Now we'll see the clinical applications of GTR. So in studies have stated that the GTR By using a guided tissue regeneration in a class 2 mandibular furcation, it results in gain in horizontal clinical attachment, and it allows the transformation of a class 2 furcation into a class 1 mandibular furcation, which can be maintained by the patient. In class 2 maxillary furcations, there are only very limited benefit. Inconsistent probing depth, reduction, and there is no additional gain in attachment loss. While in class 3 furcation, occasional success have been reported, while many reported any unpredictable results. So, GTR are more favorable in class 2 mandibular furcation, which results in a horizontal clinical attachment, and it allows the transformation of a class 2 mandibular furcation into a class 1 furcation, in which the patients are able to maintain that class 1 furcation. Using a GTR in an intra-bony defect, the results in greater probing depth reduction and attachment gain, and also it is highly predictable. So this is the defect area in which you will raise the flap, you will debride the area, and you will place the GTR membrane accordingly, and you will place the GTR membrane in position with sling suture, and then the flap is repositioned either on the same side or on the or the flap is placed coronally, and then sutures are given. So this is a technique which we'll be discussing later. So these are the results in furcation and intra-bony defects by using a GTR membrane. There are some factors which affects the outcome of guided tissue regeneration that can be either patient-related or site-related. So in a patient-related, it includes smoking, poor oral hygiene maintenance, if there is any residual periodontal pocket, or if uncontrolled diabetes. While site-related factors are the cervical enamel projections, enamel pearls, gingival biotype when it is greater than 1 millimeter, and if there is any mobility. So these are the factors which affects the outcome, either patient-related or site-related. So now we'll see the procedure for the placement of membrane. First, after anesthesia, you need to raise the mucoperiosteal flap with vertical incisions extending a minimum of 2 teeth anteriorly and 1 tooth distally to the tooth being treated. Then debride the osseous defects and thoroughly do a root planing. Now we can see the defect. So trim the GTR membrane to the approximate site of the area being treated. And care should be taken that the apical border of the GTR membrane should extend 3 to 4 millimeter apical to the margin of the defect and 2 to 3 millimeter laterally beyond the defect. So you should trim the membrane accordingly. Now, the occlusal border of the membrane should be placed 2 millimeter apical to the cemento-enamel junction, and the membrane is tightly wound around the tooth with a sling suture. Suture the flap back in its original position or slightly coronal to it using a independent suture interdentally and also in the vertical incisions. And the flap should cover the membrane completely. That is, there should not be any GTR, there should not be any exposure to the GTR membrane. So this is a pictorial representation in which after in the initial examination, we can see there is a probing depth. By using a probe, you can probe the pocket, and there is probing depth of more than 5 millimeter. So there is a localized bone loss, and a small incision is used to expose the defect. GTR membrane is placed, and then flap is repositioned. And this is the defect in which this is the defect. And in this particular case, they have used bone graft along with a GTR membrane. So after debridement of this osseous defect and also thorough root planing, the defect is filled with bone graft, and then accordingly the GTR membrane is trimmed and kept in position using a sling suture. Then the flap is repositioned slightly coronal to the original position. That is coronally advanced flap. And then it is sutured both in the interdental area and in the vertical incision area. Suture should be given and a pack can be applied. So by using a resorbable GTR membrane, there is no need for a second surgical approach. So this is it. This is a vertical bond defect. GTR or a barrier membrane is placed. So a barrier membrane is placed between the epithelial cells and the defect. So it prevents the migration of the epithelial cells and the connective tissue cells into the defect area while allowing the periodontal ligament cells to thrive, repopulate in the defect. Then it is placed in position with a sling suture and the flap is repositioned coronally to its original position and it is sutured. So there are some complications reported with GTR. They are membrane exposure, GTR membrane exfoliation, bleeding from the site, swelling, hematoma, erythema, suppuration, perforation of the membrane, and postoperative pain. These are some complications associated with GTR. So to conclude, the principle of GTR or guided tissue regeneration lies in the establishment of the cells of periodontal ligament to selectively repopulate the root surface. The use of GTR membranes can lead to significant periodontal regeneration and formation of cementum with inserting fibers, although complete regeneration has never been reported. It has considerable value as a regenerative procedures, particularly in the infrabony area, furcation defect, and in the gingival recession defects. In future, guided tissue regeneration can be combined with the use of biological growth factors that allowed for selectively control the type of cells proliferated from the fibroblast precursor. Thank you.